So we'll be moving on here to Jennifer Manley.
She's on.
Great. Professor of Neuropsychology at Columbia University. And she'll be talking about the Lifecourse causes of later life inequalities in brain health. She'll also be joining us remote. Can you hear us?
Hi, everyone.
Hi, Jennifer. Thank you.
Hi. Let me put my slides on presentation. Hopefully you can see that.
Yes.
Yes?
Yeah.
Yes.
Okay. All right, I'm going to get going. If you can't hear me, let me know. I can't hear you very well, but thank you very much for inviting me to speak. I'm sorry I can't be there. But I am going to focus on disparities in later life brain health. And just off the bat, I want to thank the people that I work with, who are, we are all supported by the National Institutes on Aging.
Hey, Jennifer, you're, sorry to interrupt, you're actually on presentation mode, so we can see like your notes and your side of things. I don't know if you want
to really?
that. Yeah.
Let me see if I can get out of presentation mode. Okay, how is that?
Perfect.
Perfect.
We got it.
All right.
Yep, we got it.
I did that in record time, too. I'm really proud of myself. Okay, so here are the people that I wanted to thank and the funds that are supporting this work. So we have some challenges in research on brain health and disparities. And one of them is that I don't believe that brain health disparities research, especially in aging, can be conducted using convenience samples. So, and that's what really proliferates in research on older adult brain health and ADRD research, which I'm interested in. Another issue for our field that I think is hampering discovery and acceleration of our research is that the people who are really expert in quantifying brain health have not traditionally focused on social determinants of health across the life course, so that measurement is really lacking in studies that have exquisite measurement of brain health outcomes, and that includes cognition and also imaging biomarkers and some of the other outcomes that you've been discussing during your conference. So it's really difficult then to track the mechanisms which I think are across these different. I agree with people who've characterized the life course mechanisms of inequalities in brain health or in aging as being this interaction between biological and behavioral and other contextual factors. It's hard to look for interactions between those causes if you haven't measured one whole big area of that experience, the social exposome. One of the other challenges for brain health disparities research is that it's been difficult to determine how biased our estimates are of these early life or life course factors and how they relate to brain health. If we haven't defined what our target or reference population is, that threatens external and internal validity of our results. The reason why that's so important is that obviously we're interested in developing targeted interventions, and if we don't know where to intervene or what the effect of an intervention would be, all of this sort of more or less observational research won't have value. And then finally, we're all doing different kinds of work in different places. The measures of social factors or social exposures aren't as harmonized as we'd like them to be in order to potentially combine cohorts and combine research, and that's also true of the brain health outcomes. And so this is another challenge. You may be a little surprised that I'm starting with my conclusions, but I just wanted to frame the rest of my talk in some of these challenges that I think are there for disparities research and then move forward. So I'm going to, if I can figure out how to move forward, there we go. I'm going to give you an overview, a little bit of evidence for disparities in brain health and in aging. And I'll touch on some of those methodological challenges that we have, and then talk about some mechanisms that we've been looking at that we think probably help explain why there are disparities in later life brain health. I am an ADRD researcher, so my definition of brain health obviously includes the lack of neuropathology that is associated with Alzheimer's disease and related dementias. But another important thing, and I've heard you say it this morning already, is that I don't think it's realistic to expect that people will age without some of these neuropathologies, especially cerebrovascular neuropathology. And so my other the one other thing that I include in my definition of brain health is resilience and reserve, because I think that is what we should expect of healthy brains is to have resilience against neuropathology, both aging, the pathology that's associated with aging, but also some of the diseases that are more common in older age. So here's some evidence. This is from the YCAP study in Northern Manhattan that in incident Alzheimer's disease, African Americans and Caribbean Hispanics are more likely to develop the disease over time. So these are people who started off this longitudinal study of Medicare recipients in the neighborhoods around the hospital here in Northern Manhattan, who at baseline did not have dementia and then were followed over an average of 7 years to look to see who developed both functional and cognitive impairment that was typical and met criteria for Alzheimer's disease. And so one thing to note here in this longitudinal study is that when you adjust for years of education or occupation or income, or when you adjust for history of stroke and hypertension and diabetes, these disparities persist. So some of the first things you would think that could potentially mediate these differences don't seem to have that big of an impact on these disparities. Many of you in the room know this study, which is fantastic, by Elizabeth Rose Maeda, who is not in my group, but works with Maria Gleamore and Rachel Whitmer in California. And they looked at the Kaiser Health Study, followed people who were in that healthcare system over many years, and found that African Americans and American Indian Alaska Natives, compared to their reference group, which they found had the lowest risk of developing dementia, were Asian Americans, were at higher risk. So They were not able to look at some of the social factors like education that might just explain these disparities in incident dementia. But they were able to pretty well, since they were working from a healthcare system, look at cerebrovascular and cardiovascular disease and found that those treatment or diagnosis with those diseases did not explain these disparities. There's also a geographic overlay to these disparities in dementia. This is Maria Gleamore, who looked at CDC death records and found that in blacks who were on the left side and in whites who were on the white side, both with respect to Alzheimer's disease on top and all-cause dementia on the bottom, there was this higher risk of dying with those diseases on your death certificate if you were born in a stroke belt state. So this is not where people die. Many people migrated out of the South and out of the stroke belt states to the North, but they brought their risk with them of being born in and raised in these stroke belt states. So there's something going on in terms of disparities, both racial and ethnic disparities, but also these geographic disparities in risk for dementia and for Alzheimer's disease. And then the racial disparity in stroke, which I think should absolutely be included in a definition of being stroke free is part of the definition of brain health. These are well-known disparities in stroke. What some people aren't aware of is that there's this flip later in life where whites age 85 and older are at higher risk of having stroke than are African Americans. These data are from the REGARD study, which is a national longitudinal study of stroke disparities. So one of the issues we have is about selection bias, and I want to just clarify that all of the studies that I just showed you in terms of evidence of disparities in later life brain health are population representative, community-based longitudinal studies. They are not clinic-based studies. And so those are the studies that provide the strongest evidence for disparities. We have a lot of selection bias largely because of the design of studies are clinic-based or convenience samples where people are recruited from clinics that specialize in memory disorders, and there's a history of stigma and mistrust that really widens the gap between people who actually have cognitive impairment and people who actually show up to the doctor with that complaint. And so these are not these sources of mistrust and stigma are not just historical. It's going on, as we speak, that people and their families are facing discrimination in medical care settings, and it makes it really less likely for them to participate in some of these research studies or even to show up where we are recruiting. So that's a real challenge. Lisa Barnes just yesterday celebrated her Crystal anniversary, which I learned is like 15 years of her study, which is the Minority and Aging Research Study in Chicago. And she's been doing this work of recruiting people from the community who are willing to give their brain after death to do neuropathological studies of people who were studied in life. And so this is Lisa, and one of her signature findings in 2015 was that African Americans who were diagnosed with Alzheimer's disease, clinical Alzheimer's disease, dementia in life, were more likely to have mixed neuropathology than were whites who had the same diagnosis in life. So first of all, I want you to notice that this was, at the time, the maximum number of autopsies she had for people with Alzheimer's disease, and that was 41 blacks. And she had her pick of non-Hispanic whites, so she picked a matching sample of 81 whites to do this research. But there are hundreds of whites in the, probably thousands in their brain bank at Rush. So the number of whites that have participated in autopsy far outnumbers the number of blacks. And one of the things she cautioned about when she published this work was that this may not necessarily mean that that Alzheimer's disease is more has more mixed pathology in blacks, but that the blacks who volunteered and showed up to her and were more likely to get diagnosed with Alzheimer's disease, may be a highly selected group. I think many of you know that African Americans who are formally diagnosed with Alzheimer's disease tend to have more neuropsychiatric symptoms, more irritability, agitation, paranoia, behavioral issues than do whites who are formally diagnosed with Alzheimer's disease. And the problem with selection bias impacts even studies that are looking to characterize neuropathology in vivo. This is from the Washington University study with John Morris. They've been recruiting African Americans into these studies with CSF, lumbar puncture collection, and also PET amyloid imaging. And they concluded in this recent study that based on the data that they had, that there are race-dependent biological mechanisms for the expression of Alzheimer's disease. There were a couple confusing things, though, in this cohort. One was that the African Americans were matched to the whites in the cohort for years of education, which I think is not representative of the community in St. Louis or in the country. And also the African Americans in their cohort did not have any more cerebrovascular disease, like white matter hyperintensities, than did the whites in the cohort. So those are kind of signals that the blacks in their study are unusual. And what they did find was that the blacks in their study had less tau. They were matched on amyloid, which is on the left, but they had more tau than did the whites. And so that's what that conclusion was all about. Continuing on in this story about selection bias, this is Laura Zahodny, who, while she was here for postdoc, looked at the MIDA study and in the YCAP study and found that for memory, which is on the y-axis here, when she did a median split in both of those cohorts, she found a narrowing of the disparity in memory performance between blacks who are in the dashed lines and the whites who are on in the solid line in the older age group. And so this is evidence for an age as leveler effect, that the people who survive into later life, who are minorities, are a hardier selected cohort than the people who are white, who survive into midlife. That's just a function of survival bias. And so these are some of the things that we need to watch out for when we're doing brain health disparities research. That survivor effect explains this crossover that I showed earlier in the regard study for stroke and across race. One of the other mechanisms that people have focused on in explaining disparities is cerebrovascular disease. And this is Adam Brickman's work, who is characterizing the white matter hyperintensities in the brains of some of our participants. He found disparities in the burden of white matter hyperintensities across race. Whites who are in the black line over the course of age, which is on the x-axis, have a lower overall burden of white matter hyperintensities compared to African Americans and Hispanics. And there doesn't seem to be an interaction with age here. Keep in mind, we started scanning when people were about 70. And so because you're not born with white matter hyperintensities, we know that there must have been some kind of interaction or acceleration at some point among the African Americans and Hispanics, but we missed it. We got started scanning too late. So that's another background message to what I think we need to do to understand these mechanisms for brain health disparities is to start earlier in age, in midlife at least, to understand some of the neuropathological mechanisms. Adam and Laura Zahadny also found that there was a tighter link between white matter hyperintensity burden and cognition in African Americans than in whites. And that was contrasted with the relationship of cognitive trajectory and hippocampal volume, which they're also quantifying in the study, finding that whites who had low hippocampal volume were at higher risk for developing Alzheimer's disease at follow-up than whites with high hippocampal volume, whereas hippocampal volume was not related to risk of developing Alzheimer's disease in the non-Hispanic blacks in the study. So there seems to be, at least in the YCAP cohort, which is a longitudinal cohort, it's community-based, population representative, there does seem to be some potentially different pathways to cognitive decline across race and ethnicity. Many researchers have been looking at genetic research to try to explain some of the disparities in brain health. Tim Homan compared Alzheimer's disease cases to matched controls who are African American and found that cases had more African ancestry than did controls. I think that the thing that we can take from this, I hope the thing that we can take from this is that African ancestry may be just a really great marker for experiences of discrimination and also social factors. So Jess Martin and Maria Gleamore in the Health and Retirement Study looked at African ancestry as determined by GWAS and these ancestral markers in African Americans was associated with having less education individually, fewer years of parental schooling, lack of receiving an inheritance from their parents, lower income, and less wealth. There are some studies of other diseases like diabetes that are also associated with genetic ancestral markers that when you account for these social factors, that relationship between ancestry and disease is accounted for. And in fact, in the YCAP cohort, we're still working on this study, but we find, I just want to direct you to the right side of the graph. This is Juliet Colon, who's actually a research assistant in our lab, and she looked at African ancestry in the Latinx people in YCAP. So these are all older adults who are followed longitudinally. We have their African ancestry, a very mixed population, Dominicans, Puerto Ricans, and Cubans mainly. And those people in the lowest quartile of African ancestry had the highest cognitive test scores, if we looked at it in this composite Z-score, compared to people with the higher degree of African ancestry. These differences are entirely explained by educational experience, both quality and quantity of education, and early life socioeconomic status, mainly driven by parents' education. So we can explain these ancestry differences with social factors. I'm going to end up showing you some data from Regards. This is that study I referred to before. It's a large cohort that's been followed for over 15 years now. The initial outcome of Regards was stroke, and now it's sort of widened out to be a study of vascular contributions to cognitive impairment and dementia. Maria Gleamore and I started off many years ago taking advantage, wanting to take advantage of the fact that the PIs of the original PIs of Regards asked people every place they'd ever lived. And so we have data of their city, county, and state residents when they were in school. And we knew that there were these from the economists had been using the administrative data from schools for many years to predict human capital outcomes and show differences across race in those human capital outcomes, and geographically based on the investment that states and counties had in schools. And so we used those administrative data. We had to go to the original biennial surveys on education to find it. And we recorded all of those administrative data and showed that, there are these trends over time. This is year on the x-axis, and also by state or geographic location in these experiences of different quality schools across race. So just the amount of time that the school was open in the South, especially among Black students, was much, much shorter than in the North. So if an African-American person who, was born in 1930s tells you that they went to 8 years of school, you can pretty much just cut that in half in terms of the typical school day of 180 years. It was open for about half the time for certain states. And that goes for student-teacher ratio too, which we're all trying to, find that magic student-teacher ratio for our own kids. We want to get that as low as possible. But Black children in some states were sharing their classroom in an elementary school with 40 or 50 other children. And that really has an impact on later life cognition. So controlling for some of the confounds, like early life confounds, family SES, and also state level or state fixed effects, we find that people cross race who attended schools with higher term length have a better payoff to years of education in terms of cognition than people who attended schools in states or counties that had lower term length. And then what we find here when we developed a sort of overall score for school quality based on these administrative records is that people, this is an unadjusted model, but for every 1 year of predicted, policy predicted years of education, 1 year for every 1 year increase of policy predicted years of education, people were 40% lower odds of having cognitive impairment at baseline in regards. When you add the confounds, including age, sex, gender, state fixed effects, and parent education in Model 4, and look at stratified models, you see this interaction where the payoff to going to higher quality schools is there especially for white women and white men, but also Black women, but isn't there for Black men. So that really makes me think about discrimination. And we've been doing a little bit of work on discrimination and cognitive function in our studies. And this is preliminary work by Shauna Samuel, who finds that in general, people Blacks with more education report experiencing more discrimination, and that there's this interaction between sex, years of education or educational credential, and discrimination on cognitive function. I'm showing you a memory test here, and you can see this trend that among Black men with graduate degrees, their discrimination experience, self-reported discrimination, is negatively related to cognition, whereas that's not the case among African American men who have college degrees or high school degrees. And then finally, just to flash this up, which is, I think to move forward, we're going to need to take advantage of studies that start earlier in age. You know now that I'm interested in education and school quality. So we've identified a number of cohorts that began when people were in high school, Project Talent and high school and beyond. And the advantage of this is that you can, because they did cognitive testing when they were adolescents, and now those people are in the case of Project Talent, older, and in the case of high school and beyond in midlife, you can track not only who survived to be in later life to adjust somehow for that survival effect, but also look at early life predictors of later life cognition. So right now, the Project Talent is being linked to Medicare, and they did find that they didn't have the power in this particular cohort to look at racial differences, but they did find that adolescent cognitive function predicted later life formal diagnosis or ICD-9 diagnosis of Alzheimer's disease later in life. Okay, so finally, to conclude, I think we need to measure racism in our Alzheimer's disease and related dementia studies, because that's how race becomes a risk factor for later life problems or inequalities in brain health. And so that's would be my main recommendation for some of these studies. And that means in part that we're going the other way around, which is taking population-based studies and including biomarkers for neuropathology, that those need to be population feasible, and that's not lumbar puncture or PET. That's probably blood tests. So that needs to be further developed in diverse cohorts. And then I think that with all of those factors measured in the same cohort, we have a chance of calculating population attributable fractions so that we know if we were to intervene on some of these social factors, what would be the impact across the life course. Highly selected samples are not going to be revealing for disparities research, and it doesn't matter how large the samples are. This is a cool study that everyone should read that looked at the UK Biobank, which I think is an amazing undertaking, an amazing resource, but because it's highly selected, our information about disparities that we get from that is going to be really problematic. I think in my domain, we really need to be clear about what are some of these convenience or volunteer samples good for, where the target population is unknown, and we have no idea how to weight our estimates. And then finally, these social forces should be acknowledged explicitly in national plans to reduce the impact or burden of brain neuropathology and ADRD on our population. We're working to explicitly make the case that early life economic and social policy is brain health policy, and these are some of the ways that may take place, or that we would be able to reveal this in a causal way. That's it.